Hello everybody. So here is the answer to the quiz on the 7th of August. So this is a 23-year-old male with a 1-year history of itchy papules merging into plaques on the lower legs. He apparently had similar lesions before, around 6 months back, which cleared with treatment. So clinically, a number of differentials went to my mind, including lichen planus, folliculitis, lichen simplex, chronic eczema, or psoriasis. So this was the clinical pics, as you can see. Only on the legs, actually, he had these sort of itchy plaques. Few of them are papules. Not particularly centered around the hair follicles. There were some lesions out with the hair follicles as well. Now, you can see on low power, what you're seeing is a psoriasiform dermatitis. Why do I say it's psoriasiform? Because there is pretty much regular elongation of the reti ridges, which seem to be clubbing together. What is unusual, or what is different from regular psoriasis, is that in typical psoriasis, you should find that the reti ridges are often bulbous at the tips, which they are not. They're just elongated and clubbed, but they're not actually bulbous. And often in typical psoriasis, you see suprapapillary plate thinning. Now, suprapapillary plate thinning means this is the dermal papilla. Above the papilla, the dermal plate should be thinned out, but it isn't. If you look at this is pretty much the dermis pretty much ends here. The epidermis pretty much ends here. So the suprapapillary plate is not particularly thinned, but there is some parakeratosis here which you can make out. There are some dilated capillary loops in the upper dermis, which is fine. Just because you have dilated capillary loops does not make this psoriasis, though, remember. What I am looking for to call this psoriasis is more of sort of the bulbous tips of the reti ridges and suprapapillary plate thinning. Subcorneal neutrophils would be good as well, but they're absent here. You're seeing focal parakeratosis, but no real subcorneal neutrophils. There is a very sparse lymphocytic infiltrate in the upper dermis. Now you can see higher power, what you're essentially seeing is a spongiotic dermatitis. You see marked spongiosis here. All this is spongiosis. This is all spongiosis, which you can see the desmosomes in between the epidermal keratinocytes and parakeratosis. There are no neutrophils really. So psoriasiform acanthosis is present, but it's not psoriasis. There is no lichenoid interface dermatitis. There is no acantholysis. There is no pityriaciform spongiosis. There is spongiosis, but it's not pityriaciform. What pityriaciform spongiosis actually means, you should go back to one of the previous quizzes to get the answer. There are no subcorneal pustules. There is compact hyperkeratosis. Yes, in places there is compaction of the hyperkeratosis. You can see here there. There is parakeratosis, but there is no suprapapillary plate thinning. Now, what are the clear spaces the eye was pointing at? This is a very easy question. These are sebaceous glands trapped within the hair follicle unit. These are all sebaceous glands. You can make them out because the nucleus is central and you have a foamy, sort of bubbly cytoplasm, and nucleus is in the center of the cell, center of the sebocyte. In contrast to adipocyte, where the nucleus is pushed towards the periphery and you don't see this bubbling in the cytoplasm, it's more of a clear cytoplasm in the case of adipocyte. All right. So let us see what these labels show. This is an eosinophil, typical bispectacle nucleus. Here is an eosinophil. Here is an eosinophil. Now, eosinophils often imply either an infection, usually parasitic infections, or drugs, but neither of these are absent here. It's neither a parasitic infection nor drugs, and the history is not really typical. So I don't really know why they're eosinophils, but eosinophils can be present for an n number of reasons, and not always do you need to attach significance to them. Number 2 is a lymphocyte. Number 3 is an endothelial cell. Looks like a histiocyte, but it's lining the endothelium. This is an endothelial cell. This is more of a flattened endothelial cell. This is slightly more sort of plump. Number 4 is a red blood cell, RBC, which can be present in any inflammatory condition. There can be RBC within the vessel or slightly extravasated, as you can see here. And this is a melanocyte, okay, melanocyte with a perinuclear halo. Melanocytes are typically present around the basement membrane in a 1:8 ratio, all right. So the final diagnosis is in fact Lichen simplex chronicus. I told you why this is not psoriasis. Lichen planus does not, because there is no lichenoid reaction. Pemphigoid nodularis, you should be able to actually see a blister to call it pemphigoid. Perforating collagenosis, there's no perforation. This is simply a chronic spongiotic dermatitis, and the clue to this being a chronic condition in Lichen simplex chronicus is this vertical alignment of the collagen bundles. You can see here that the collagen bundles here are horizontally oriented, but as soon as it comes to the papillary dermis, they become vertical in orientation, and this is because of chronic scratching. You can see this even in itchy psoriasis, for example. If any skin condition that has been scratched for a long period, the collagen bundles become vertical in orientation along the papillary dermis. All right. I hope you enjoyed the quiz. Thank you very much.